Assalamu alaikum and good morning, good day, good evening. Let me screen share and see if it is working. Okay, here we go. Can you see the screen now?
Yes.
Okay, thank you. So today we will be talking about minimal change disease, a case-based approach. I have maybe 1.5 cases. Dr. Ah has a case. Really, the main purpose is to generate some discussion. I know we have discussed pathophysiology in the previous sessions when we had like a GN pathophysiology session. So I really want to focus on case, maybe some treatment, some basic understanding and some discussion. So for Project ECHO, as we always say, this is all teach, all learn community. So it's not that it's not unilateral. Anybody can teach, anybody, and all of us learn. So in the spirit of ECHO, we are usually on the first name basis. So please turn off your microphone if you're not speaking, and if possible, please turn on your cameras because that's always helpful. So again, as I mentioned, so we will have some cases today to discuss. You might have received an email. This is the disclosure that comes from Project ECHO. So please make sure that you share your feedback and fill the evaluation, because that helps us to sustain these programs and gives us feedback as well. So in the end, for example, 2 years later, if you want to write like a summary of the whole session, your feedback is what we need to generate some objective data to do the write-up. So let's start with the case. And again, I think I opted and chose not to dig too much deep into some of the topics we covered in the past. So interactive session, please feel free to share your thoughts at any time. So a healthy 22 years old male, he just started med school and he was visiting his home for the summer break. His mom is a physician in my town, and his med school was in Pittsburgh, so roughly 3.5 hour drive from here. So he developed very quick lower extremity edema, finger, hand swelling, face swelling after a bad cold. Very classic presentation of a nephrotic syndrome. He is not on any medication, so he has proteinuria. His protein to creatinine ratio was 14. He has normal creatinine at that time. His albumin was 1.4, cholesterol was 350. So we did a kidney biopsy, and the biopsy showed somewhat similar to what we have in the picture. This is not the exact biopsy, but this is the picture. So maybe just as a starter, if we have some trainees in the room, residents, fellows, what would you treat? So the hint is that this patient has minimal change disease on the biopsy. So what is your choice? A, B, C, D, or E? You can actually write or type in the chat to see how would you like to do? How would you like to treat this patient? So the chat started. So all right, we have 2 C's and others.
Actually, anyone want to comment on the biopsy itself?
Dr. Agha, if I don't have a volunteer, then maybe can I ask you to comment on the biopsy?
Yeah, I mean, this actually is not a normal glomerular. You can see that the capillary lumens are a little hard to see. The tuft is actually beginning to collapse on itself, and you see some podocyte hyperplasia there. So this may actually not be a classic minimal change disease slide. This may be a collapsing GN slide. you can't see the capillary lumina, right? So some of them you can see, but over here, completely collapsed, here, completely collapsed. You can see this podocyte hyperplasia. I'm actually moving my mouse so you can't see
Your mouse. What do you think on the
anyway.
EM?
Yeah, so on the EM, what you're looking at is diffuse podocyte effacement. So you can't see foot processes at all, and you don't see any deposits. So the EM is perfectly fine. Um, the biopsy slide, the H&E might not be classic minimal change, just to point that out. But for the sake of this conversation, let's assume that the H&E was completely normal.
Mm-hmm. So again, I think this is the number one GN whenever you start the book. So most people are comfortable starting with the prednisone. So and that was the right answer. Anybody who would like to do maybe another approach for the first timer, like some fancy medicines? Probably not. So because we have very robust data for prednisone, and we all know, I'm sure all of us has experience of treating this condition. So key pathology features: light microscopy is normal, immunofluorescence is normal, and EM shows really diffuse podocyte foot process effacement. But pathogenesis, although we have made a lot of progress, but still I think the unknown or not completely known is part of the pathogenesis. Is this a T cell problem, a B cell problem, a combination of both? Because you are making some assumptions based on some association, because T cell good remission with glucocorticoid occur in Hodgkin's as a secondary. It has some association with allergies. Urinary CD80 is coming as a biomarker of disease activity, and there is some progress on that front as well. Let's see how this pans out. Is this a B cell dysfunction? Because once you use rituximab, there is good response. Is there a circulating factor? In the picture you see on the top is really the normal filtration apparatus with the capillary side, where the albumin is unable to filter through because of the barriers. There is endothelial fenestry, there is charge barrier, there is podocytes in a certain configuration. So once you mess up with the filtration barrier, there is proteinuria, and this could be very massive and high intensity, can lead to very quick nephrotic syndrome. So this is the age. I just found this.
Can I quickly interject? If you could go back to the previous slide, please.
Yes.
So one thing that actually is very topical and we need to maybe touch on is a very recent set of papers that came out, which are looking at the incidence of antinephrin antibodies in minimal change disease. So if you look at the top part of this carton, you see part of the slit diaphragm apparatus has two proteins, nephrin and podosin, and mutations in nephrin lead to congenital nephrotic syndrome, which is known as the CNS of Finnish type, which leads to infantile nephrotic syndrome, which is not something we see as adult doctors of adult patients, but Dr. Lainwala and other pediatric nephrologists definitely see them. But it seems like there's a subset of patients with minimal change disease who have antinephrin antibodies, and that is the basis of their particular disease. So the circulating factor may not be a monolithic entity. It could be different types of proteins that generate different types of disease processes with the commonality of an acute diffuse podocytopathy. So the classic presentation of minimal change disease as of focal segmental glomerulosclerosis is an acute diffuse podocytopathy, just as the case that Umar presented, where you have acute onset nephrotic syndrome, thunderclap surprise, usually young people, they come in and say, for the past week, my legs are swollen. And when you look at them, they've got, nephrotic range proteinuria. The cholesterol is very high, and typically of all the nephrotic syndromes, minimal change disease has the highest cholesterol values. So it has frank selective proteinuria to begin with, in contradistinction to membranous, where you have non-selective proteinuria. So part of the pathogenesis of this is now antinephrin antibodies, and this is going to be the nidus for further discovery, just as PLA2R was for membranous, that we'll start peeling off strip by strip the various different types of antibodies or factors that can lead to minimal change disease. So in a situation like that, high levels of antinephrin actually can also predict relapse after transplantations. As a transplant doctor, this gives me a marker in some of these patients. So this is an exciting time. For the first time, we've really touched on something which is substantial. CD80 was all the rage a few years ago. There's actually an anti-CD80 monoclonal antibody, which has not been shown to be effective in these patients. So we're not certain where CD80 is going to go. But it's just topical to know about the antinephrin antibodies and minimal change disease. So I'll shut up now. Thank you.
No, thank you. This is great update, and I think somebody shared that that article very recently in one of the discussion groups. So Dr. Lenwala, you raise your hand.
Yes, just to carry a little bit forward what Dr. Aga was saying. This nephrin-induced nephropathy, the congenital nephrotic variety, is usually a very severe one, starts before 3 months of age. Children would go into renal failure almost inevitably within a year or so. And in our cohort of about 100 children that we have seen in the last 15 years in Pakistan, except like 1 or 2 who survived, almost everyone died. And there was not much that we could do. Those who survived were the ones who just got cured miraculously and without any immune suppression or without any real medicine. My query here is that if adult MCD was to be labeled as a defect in nephrin alone, then the presentation and the response to therapy of MCD just to steroids, they just are two different entities clinically to me. The other MCDs that we see of other age group of children, they are so steroid sensitive, and it's not so such a bad disease. It does not progress to renal failure that rapidly. So to me, this discovery of antinephrin antibody, I think it's just a tip of that iceberg. I'm still not sure.
I think those are all very astute observations. So just to clarify, the congenital nephrotic syndrome is actually because of genetic abnormalities in nephrin. The nephrin itself is defective. So you get frank nephrosis, like Dr. Lanewala said, very early after life. And you have, a heavy burden of that disease because it's so severe, and most of these kids end up on dialysis, get early transplants. In fact, the first time I looked at antinephrin antibodies was in someone with congenital nephrotic syndrome who were transplanted and then developed antinephrin antibodies later, because the wild type nephrin was different than their mutated nephrin. So it was almost an autoimmune phenomenon against normal nephrin in the transplanted kidney, much like sometimes people with Alport syndrome develop anti-GBM disease because of antibodies that are generated against the glomerular basement membrane, which is normal. This entity, this is an association study, probably causal in those particular cases, where you look at the sera with minimal change disease and you kind of test them for various things, and they found antinephrin antibodies. So this is actually more like a slit diaphragm membranous type deal, where you have an antibody that goes in and attacks the slit diaphragm and makes it leaky. So the corollary to this is that this would then be responsive to immunosuppression because antibody is being generated, and that antibody is then attacking the slit diaphragm and leading to slit diaphragm dysfunction. So treatments targeting antibody production, steroids or rituximab, etc., would be useful in that scenario. Whereas in congenital nephrotic syndrome, it is not amenable to immunosuppression because it is not an immune problem, it is a structural problem.
Okay, thank you.
Thank you for wonderful discussion. So this is something which I found in this article interesting. This is if you see the age and how the different nephrotic syndromes have their spectrum. So this is the kind of childhood 1 to 15, 20, you see the minimal change disease. I always thought minimal change disease has a bimodal too. So there is another second age when the percentage of patient with nephrotic syndrome, minimal change has an increase, but maybe in this study, the population they looked at. So you can see the minimal change disease. I'm sure Dr. Lainwala, they see this way more than what we see in the adult practice. And membranous on the other side of the spectrum, it's a function of time, a function of age. You see more towards later years, and FSGS, I can see that it has kind of very steady presence in the adult population. Any comment on the kind of the percentage of the presence of nephrotic syndrome in relationship to the age, or any experience you want to share?
Well, most of these nowadays, since the days of ISKDC, that was International Study of Kidney Diseases in Children, that was done in I think late 1970s. After that, we have stopped doing biopsies in children, and we presume all of them to be having minimal change because in ISKDC, 85% or 80% of those children, everyone was biopsied at that time, and everyone had minimal change. So now we just assume that all steroid sensitives are minimal change, and that's why they are showing, I'm not sure, I mean, they do not have a tissue diagnosis of these children now. We do not do biopsies on steroid sensitive children. We do only on steroid resistant ones. Previously, we used to do steroid dependents also, but now we have stopped doing that too for the last 7-8 years. So this is just a presumed data that all 80-90% of these are minimal change. And this is just based on the fact that ISKDC had seen all of that. I am still skeptical that I wonder, because now there is a described entity which is called a secondary steroid resistant group. Those who are steroid sensitive in the beginning would develop steroid resistant later on in the course. And when you biopsy them, most of them have FSGS. So I was just wondering that maybe to begin with, their morphological lesion when they were steroid sensitive was not a minimal change, or is this a subgroup where the lesions evolve or change into something else? At its best, to me, it's still a mystery. I really don't know, and I don't understand. Most of the things that our knowledge is based on assumptions, based on knowledge that we have acquired a long time ago from seminal papers, and we do not know the exact ones now. Has it really changed? Is it the same in our population too? I'm not sure.
I think jury's out there. We have our pediatric nephrologists, they have similar approach. Not everybody ended up getting a biopsy, only select patients. Once they have very typical presentation and course, we don't do, our pediatric nephrologists, they don't do biopsies. So some of the observation on the adult side, this was again, I think, a summary of some presentations. So when you see most, so mid 40s, on the adult side, but again, there's some wide spectrum. Creatinine, and you know that the AKI is present in 18% of the patient and maybe more with minimal change disease because of all those hemodynamic mediated changes predominantly. And albumin is low, on average 2.2, cholesterol is high, protein is like 9.9. So you also see a good like 1/4 of the patient, they may have microscopic hematuria. Contrary to the belief that hypertension, is also seen in many of these adults. So I recently saw a patient who creatinine was 3 on presentation. It went to 4 and 5. He was in the hospital. We had to give him fluids first or back off in his diuresis for a day or two before he started to have a decline. And his biopsy actually did not show any meaningful changes on the tubules. I was expecting maybe an ATN, but he did not. It was all minimal change disease. I think probability of remission very high in children earlier on. So after weeks of treatment, children tends to remit very quickly. Adult, this is like, they take some time for the onset of remission. So really weeks after treatment, when you start to see remission in the adults versus children. And I think this phenomenon, I'm sure we have all experienced and seen.
Just to make a quick point, Omar, this is why the definition of steroid sensitivity in children and adults is different.
Mm-hmm.
So in children, steroid sensitivity is defined as response to steroids. Previously, it was 4 weeks. Correct me, Dr. Lainwala, has that been moved to 8 weeks now? Whereas in adults, it's 16 weeks.
Yes, it's the same, I think.
4 weeks for children, if there is no response in edema and proteinuria. But if the proteinuria has decreased a little bit or edema has decreased a little bit in 4 weeks, then we may extend it up to 6 weeks. This is most of the guidelines. They may differ. Some of them would go up to 8 weeks. French ones would give pulse doses of steroids before labeling them as steroid resistant. Indian guidelines are different. Italians are different. American KDIGO is different. Most consensus, Pakistani consensus was 4 weeks if no response, and for partial response, 6 weeks.
Very good. And for adults, it's 16 weeks. It's definitely different. So
yes.
I would like to thank both of you for having a communication back and forth, because I think this is really increasing even my knowledge as a presenter. I recently updated, so thank you both of you. So this was another, I think, so like how do we treat? So some patients are treated with daily steroid use, and some patients are treated with every other day steroid, alternative day steroid use. So who responds before? So in the middle, the solid line is really all remission times, whereas the purple one is daily and the red one is alternative day. You can see that the purple one is winning the streak by a little bit. So maybe there is a slightly early response with the daily dosage schedule. So some definitions, and we just talked about all these definitions. Sometimes these definitions can become a bit confusing. So I would probably spend a few minutes to go through. And these are from this article by Marina Vivarelli, and I think there was similarities in UpToDate as well. This was a little detailed. So nephrotic syndrome, 3 things: edema, proteinuria more than 3.5 grams per day in adults, and children is more than 40 milligram per meter square. Per H, what is per H, Ali?
Hour? Per hour.
Per hour, okay. So
that's about a gram in a day.
It's 1 gram in a day?
Gram per meter square.
A gram per meter square. So this is how it is. Okay, thank you for, and low albumin, less than 2.5. Remission is based on clinically remission of resolution of edema, albumin, which is normalized more than 3.5, really reduction in proteinuria. Now, if the reduction is, so what would you describe as complete remission? If in kids it goes below 4 milligram per meter square per hour, or negative on dipstick, and adults it's less than 0.3 grams per day. Partial remission, which if the proteinuria is not completely gone, so but decreased by 50%, and albumin is more than 2.5 in adults, and children is less than 2 gram per 1.73 meter square. And then, so Ali, let me ask you for my own knowledge. So the first one is 4 milligram per meter square per hour. Second one, they wrote less than 2 gram per meter, like, this standardized 1.73 meter square. So can you please help us understand these terms?
Sure. Recently, IPNA, International Pediatric Nephrology Association, has come up with guidelines on nephrotic syndrome, and KDIGO also came out. So all these things have been revised now for definition too. For definition of nephrotic syndrome, they have made edema plus minus now. Okay. So you don't really need to have edema for the diagnosis of nephrotic syndrome. It's just massive proteinuria. And that too, they have given it as a gram per meter square. So for a 30 kg child, it's 1 gram in a day will make them nephrotic. And for a 15 kg per child, it's only 500 milligrams in a day. So it's not that very like 3.5 gram like an adult. Some 2+ or sometimes even 1+ proteinuria can be nephrotic in a very small child. So the mainstay for the diagnosis is this presence of proteinuria, and because these cutoffs can be so confusing to calculate and to exactly measure. So what we, for our clinical practice, what we say is enough proteinuria to cause hypoalbuminemia and plus minus edema. So that would give, and when you're in doubt, you check the cholesterol, and if there is hypercholesterolemia, then it will make it as a nephrotic syndrome. So that is for the first definition. For the remission, we say that negative or trace proteinuria on dipstick for 3 consecutive days. And usually the median time to respond is 7 to 11 days. It should respond by 4 weeks. If not, then it's steroid resistant. And for partial remission, we say that if the proteinuria, if the albumin, serum albumin is more than 2.5, with we don't really quantify the protein if it's on the dipstick as much protein, but if it has allowed the albumin to come up by 2.5 and there is decrease or resolution of edema, then we treat them as partial responders. Okay. But for steroid, partial response even at 6 weeks would label them as steroid resistant. And we would then do a biopsy and treat them with alternates other than steroids. So partial remission with steroid therapy in children is still no response after 6 weeks.
Okay, so the time becomes an important variant. So, and the relapse is like, really the recurrence of proteinuria and positive, again, urine dipstick in kids, as you mentioned. So this was the table about the steroid sensitive nephrotic syndrome and steroid dependent nephrotic syndrome. And there was a category about the multi-drug resistant nephrotic syndrome. So I think we discussed about the sensitivity is response in 4 to 6, and I think 4, like as you just corrected. In adults, that time frame is 16 weeks because some of the adults, as I showed you, there is delay in response, or maybe response is not as quick or robust as compared to children. There is a non-relapsing flavor. There is no relapse for more than 2 years after the end of therapy. This is applicable to children, not yet defined in adults. And there could be either an infrequently relapsing nephrotic syndrome or a frequently relapsing nephrotic syndrome. The infrequent is less than 2 episodes in 6 months or less than 4 in 12 months. And if this is higher than that, that is frequently relapsing. Steroid dependence. So a relapse while on steroid therapy or within 15 days of discontinuation. And then, as we talked about that, this could be steroid resistance as well, which is no response. In children, it's 4 weeks, and in adults, it's 16 weeks. And multi-drug resistant, I think it's poorly defined. If you're not seeing any response after 6 months, or absence of complete remission at 2 years, so really stretching the limits towards the other extreme. And in this situation, multiple different treatments have been tried. So how do we treat? This is really like a simplified version. Initial therapy in adults is prednisone 1 milligram per kilogram per day, max 80 milligram per day. Or if you want to go with the alternate day, then 2 milligram per kg per day, which is maximum 120 milligram. Minimum therapy 4 weeks, maximum 16 weeks before you start the taper over 6 months. Alternatives, if prednisone, either you cannot use, side effects or contraindication, and I will go about some of the responses about cyclophosphamide, CNI, Cellcept, the mycophenolate mofetil, as well as rituximab. So let me ask my colleagues about, maybe Ali, if you can help us, how do you use steroids in this 6 months? And maybe Dr. Aga or somebody else from the group, that in adults, how do you use that? Like, when do you start the taper? Ali, you want to go first?
Well, yes. In children, this is completely different. And now, since 2012 till 2019, there were 4 different multi-center, randomized, placebo-controlled, very strong studies done in different parts of the world. Started from Belgium and Denmark, and then they did it in India, and then Japan, and then UK, Prednos. So all of them have looked into this duration of therapy for first episode of nephrotic syndrome. And they have all proven that longer therapy versus a shorter duration of 8 to 12 weeks does not make any difference in terms of number of relapses that these children would get. So now all the international guidelines would recommend treating these children with 2 milligrams per kilogram per day for first 4 weeks, and then for 1.5 milligram per kilogram every other day for next 4 to 6 weeks, or 4 to 8 weeks. So total 8 to 12 is the duration of therapy. And the maximum dose is not above 60 milligrams.
Thank you. Avas, can I pick on you? Are you able to speak? What's your experience in the adults?
I mean, obviously it takes longer for a response, but if the patient is responding, goes to remission, then we wait for a couple of weeks, continue same dose, and when a couple of weeks gone and the patient remains in complete remission, then we start tapering off them. Like 5 to 10, or like a slow tapering we do, because you have a more longer tapering off you need for that. It could be 4 months or 6 months total taper off, but again, you wait about 2 weeks after complete remission on the same induction dose before we start tapering off.
Thank you. So the patient I presented, the medical student, he achieved remission in 2 weeks, and we encourage him to continue the same dose. But I think he decided to stop the steroids very quickly after he achieved remission. So 2 weeks later, we got a call that he is back in relapse, which is I was not surprised. So next time when we did really continued the high dose for a little longer time after he achieved remission. So he again achieved remission very quickly, which is, I'm sure you see this in the pediatric world as well. So
Yeah, Dr. Madiha has asked, she's another pediatric nephrologist with us. She has asked, how should you treat the adolescents? That is still a big gray area that we are not sure. Should we treat them as adults for 4 months versus as children for 4 weeks? The one with 12 to 18 years of age with the first episode of nephrotic syndrome.
So I don't have any experience with that.
Okay, so we had published a paper where we had done this. Our protocol at SIUT is that any adolescent who is like more than 12 years of age and below 18, if they would come with the first episode of nephrotic syndrome, we would do a biopsy. The biopsy patterns of these adolescents is very different from children and adults. It's in between. They're like the membranous is only 25-30%, then followed by FSGS and then MCD. And the steroid response and the treatment regimen, it's like there is not much data about this. So at this point, we are treating them as children, and we would give them a full dose of steroids, 2 milligram per kilogram per day for 4 weeks if they respond. And if they don't, then we change them to alternate medications like cyclosporin. But as time is passing and we're seeing more such adolescents, I'm not comfortable in labeling them as steroid resistant at 4 weeks. And that's what Dr. Madhi, I think, is also pointing out towards, is that should we be waiting for at least not 4 months, at least a little longer with a lower dose for these adolescents before going on alternate therapy? We're not sure.
No, thank you. I think it makes clinical sense to us as well. So that's great. So I think this is really the remission rate with different types of therapy. So when you use the when you have initial episode without any contraindication to steroids, the remission rate, whether complete or partial, is 80 to 90%. And if you have an initial episode with contraindication to steroids, then the remission rate with oral cyclophosphamide was like 75%. This was given for 8 weeks. Cyclosporin, 75%. Tacrolimus, I think they did not know, which I can imagine might be similar to cyclosporin. This was some of the summary of some of the slides, some of the trials at that time. I don't think this has any of the pediatric trial included. So this was treatment of steroid resistant, steroid dependent, and frequently relapsing minimal change disease in adults, and looked at the different response rates with oral cyclophosphamide, with IV cyclophosphamide, which was given. Oral was for 8 weeks, the IV was 6 months plus steroids. When you use or anyone has used, I have not used oral cyclophosphamide for this condition. How long do you go then? Is this for 8 weeks?
8 to 12 weeks.
And then do you use along with prednisone, or this is single therapy?
It depends, but usually when I've used cyclophosphamide, I've used it alone. Okay.
So, and I think there was some trials with cyclosporin plus minus prednisone, tacrolimus with the same, and MMF, and you can see that the response rate is pretty decent with these therapies. So rituximab, multiple observation studies as a steroid sparing agent. So this is really the relapse, the number of relapse per patient per year. And after rituximab, it actually helped with reduce the number of relapses, both in adults as well as in children. So right now, I think the options which we have are in a steroid dependent or relapsing patient. So steroids still are the mainstay primary therapy if somebody's steroid dependent, resistant, or relapsing. So we can use oral cyclophosphamide for 8 weeks, cyclosporin 1 to 2 years, tacrolimus 1 to 2 years, Rituximab has been tried like one course, and MMF, which is mycophenolate mofetil, again for 1 to 2 years. So the answer, I think everybody was right on that. We treated with prednisone. I told you that patient stopped taking prednisone weeks after he achieved quick remission. Then he relapsed 2 weeks later. He was in the middle of his course, so we had to find him a nephrologist in local town. Then he completed six months of steroids with a taper, and he did well for 2 years, and he had one relapse after that, which was again treated with another course of steroids, and he has not had any problems since then. I was recently updated about it. So I have another case, and I will probably ask.
Can I have one question before you go to next case?
Please.
Yeah, that duration of treatment with the non-steroidal, like with the tacrolimus or cyclosporin, you said 1 to 2 years. I'm just.
This is what I found in the
what other people experience about that, because I have treated some patient and didn't require that long treatment. After 6 months, I was able to discontinue many patients, and they did fine. What's the experience of other colleagues are? How long you treat with the patient with the cyclosporin or tacrolimus or Celcept?
Can I share my experience of children?
Please.
No, I mean, I know that's different, like totally different. Their response. I'm just, yeah, please go ahead.
Yeah, for children, cyclosporin, rarely you can stop it in 2 years. And if you do, most of them would come back with a relapse. So it's usually they stay with a very low dose for a very long time, for years, many years. Cyclosporin and tacrolimus, there is a difference only in the side effects, side effect profile, the cosmetic side effects of cyclosporin. So if they are developing gingival hyperplasia or sutism, then we change them to tacrolimus. Or if they are not responding to cyclosporin, some of our children who have not responded to cyclosporin would respond to tacrolimus. And at its best would give them, if there were no response, then they would go to a partial remission. There is no like dramatic, miraculous thing. MMF alone for steroid resistant variety does not work. There were some studies on steroid dependent ones, and the MMF, they had shown to work very well in the Canadian cohort, but the problem with that study was that all those children were getting steroid low dose along with MMF. In our experience, if we stop that low dose steroid, MMF alone would hardly continue to prevent that relapses. So in combination with any other medicine, MMF may be a good idea, that you can decrease the dose of the calcineurin inhibitor, but alone MMF itself for nephrotic syndrome has not shown any promising results. There is one more drug that in frequent relapses that we use is levomizole. That is an anti-helminthic drug, which is also an immune modulator, and it works good with frequent relapses in a higher dose, and that too is a 2-year course. So that limits its applicability.
So I think, Avas, maybe I can share. Let's see what my case has. It has probably some of the problems, which the duration of CNI. So, and then we have a third case, which Dr. Agha will lead. So case 2, a 27 years female. She came to see me as a second opinion. She was already following up with a nephrologist. She recently got married and now planning to get pregnant. Background is that at age 10, she was diagnosed to have minimal change disease. She responded very well to steroids. Between, for the entire duration, she was with pediatrics between 10 to 18. She had frequent relapses. They tried cyclosporin with some help in reduction in frequency of relapses, but anytime, but she has had many courses of steroids as well on top of sometimes baseline cyclosporin. Sometimes she was off the medicine. So there was some mixed compliance as well for the patient. So when she transitioned from peds to adult nephrology, all the medicines were stopped. I think she moved to a different state. And then she told me that for 5 years, and despite of not taking anything, nothing bad happened. So then roughly, age 23, 24, she started having relapses, and she had like in less than 2 years, 4 or 5 times. Every time she was on steroids. Once they taper, everything is good. They stop, she's back on it. So now she's on tacrolimus as well as low dose prednisone, and then has not had any relapse in the last maybe 2 or 3 years. Now she got married. She wants to get pregnant. She is scared, and she was told by her nephrologist that stop all medication, stop prednisone, stop tacrolimus, get pregnant, deliver a healthy baby, then just like go about it. So this was the starting point. So what would you do? Would you stop her medicine because she has not had any problem in the last 3 or 4 years, but her history that she's going to get into a problem, and now she wants to get pregnant? I think anybody can share their approach in addition to my colleagues in panel. Because somebody told her, one nephrologist told her clearly that the tacrolimus and steroids, those are not good for the baby.
I mean, okay, just let me start the discussion. I think, first of all, I'm happy that I'm not a nephrologist. Okay. So I have to take this decision, but we have, not personally, but my colleague, they have the experience patient on steroids and on tacrolimus, and they have went through healthy, full pregnancy without any problem. So cyclosporin and tacrolimus are not entirely safe, but relatively safe during pregnancy if patient needs that. So in this patient, I think stopping is everything with a little bit risky. Maybe she should continue a little bit of steroid at least. And if any sign of any relapse, I think tacrolimus is acceptable during pregnancy, or cyclosporin also.
Yep. Hina also, I think, just said in the chat that she would like to continue. Around the same time, so see that sometimes, you have the experience. So we were dealing in the hospital a patient who was another young female who was pregnant and who had a nephrotic syndrome, which came during the pregnancy. So that patient did really bad because of the nephrotic syndrome. Pregnancy was very difficult, all the edema, and that patient had a bad outcome with the baby, and patient developed renal failure, for which she's still on dialysis and still under our care. And this is like 5, 6, 7 years ago. So I had a discussion with her, and I did what Dr. Masood said, that based on your history, based on your what has been happening with you since the age 10, it is best to get you through the pregnancy with the help of prevention of relapse medicine. And so I continued her Prograf and steroids. So fast forward, we were monitoring closely with MFM, which is the maternal fetal medicine. She was with the high risk Kobe team, as well as I monitor her closely. Everything, stayed very well. She had a very good pregnancy outcome, healthy baby, full term, and everything went well, except that she had one complaint that her face was, she said, like, my face is more moon face than it used to be. I think pregnancy probably added the effect of steroids, which she had taken over the years. A year later, and I explained, I mean, we continued after the delivery. A year later, she had some medication non-compliance, which we found out through the pharmacy refills and all that. And she was going through, I think 3 or 4 relapses in 12 months. So I put her back on tacrolimus, as well as anytime she had a relapse, we gave her high dose steroids and then started the taper. I think the compliance, taking care of the young child, she would say that she would miss some doses of the medicine here and there. And then she started having relapses again. What would you do next? Now she doesn't want to get pregnant again. So somebody's having medication non-compliance.
So this is a fit case to give her rituximab at this point and be done with it.
Yes, so exactly that's what we did. Anybody else would have done rituximab? So she actually read about it because when I brought this idea up first, she was not too keen. And then I think there was some insurance payment issue. So then with one of the episodes, she came back to me and she said, like, I want to do it because I cannot take this Prograf and all that. So till date, as of today, this is now she's 33. So maybe 5 years, I gave her rituximab. She has not had any relapse. So the question I have for the group is like, should she remain on Prograf and low dose prednisone, both of them, either of them, after completing a course of rituximab?
I guess not. Because if she went to remission, right?
Yes. So every time, so this is very switch on, switch off. So very classic, presentation, and then all of a sudden, no protein in the urine.
Yeah, hopefully she will do okay on, remission, maintenance dose of rituximab without other medications.
I didn't give her any. So she just got one course of rituximab, like, 5 years ago.
Oh, one course. I thought you kept on maintenance. Okay. We have 6 months or so.
So should she be on maintenance Prograf and or prednisone?
No, she should not be on Prograf or steroid. She's just on maintenance dose of rituximab.
Okay, she's not currently on maintenance dose of rituximab. The question is, we gave her one shot of rituximab.
Per se, I don't have an experience, so I'd like to hear from the others there how the experience with rituximab. I have not had single patient with rituximab and minimal change. So,
but there's two or three things to answer here, right? So first thing is maintenance of remission, right? Mm-hmm. So you've treated her for long years on cyclosporin Prograf and prednisone, so she's now in full remission for 5 years. She's gotten rituximab. So it may be time to wean off the immunosuppression, the maintenance immunosuppression. Aves's question is, somebody who is thrown into remission or maintains remission with rituximab, what is the best way to treat them, right? So there's some people we give one dose and then we fire that dose and forget and they never relapse. There's other people who will relapse. The median time to relapsing in minimal change disease is about 9 months after a dose of rituximab. So in patients like this who have demonstrated very significant tendencies towards relapse, I would tend to consolidate with 1 or 2 more doses of rituximab. And sometimes what I do is I look at CD19 counts. If they've released, I might give another dose at 6 to 9 months. If the CD19 count is significantly suppressed, I might not, might just watch them. There's other cases, and the case I'll present in a second will be kind of like that, who haven't had this kind of a serious relapse problem. In those cases, I would just probably give 1 dose of rituximab and see how they do. So it depends on what you're looking at. There are papers looking at all these different approaches. Some people give yearly shots or 6 monthly shots, like Aves was suggesting. Some people give a dose and then check CD19 counts. Some people just give a dose and let them declare their disease. And if they relapse again, then they would give another dose of rituximab and then suppress it. So I think this is different diseases in different people. This particular patient, she has relapsed every time she's messed up. So apart from the first 5 years when she didn't relapse after taking the medicine. So in her 20s, she's relapsed more frequently. So I'm with the rest that I would probably have given her a dose of rituximab, weaned off cyclosporin or TAC and prednisone, and then give her another dose maybe every 12 months for a couple of years, and then let her fly and see what happens. But there's different ways to skin this cat, to be honest. If all it takes is a little bit of TAC and prednisone, 5 of prednisone and a little bit of TAC to keep her under control, that's fine too. But she's young, she's in her 20s, and to subject her to that treatment forever is a rather large undertaking. But that is the problem with calcineurin inhibitors in minimal change disease as well as FSGS. Once you stop them, you relapse.
So I kept her on the low dose TAC with the goal level, maybe 4 to 5 kind of goal level, not very high. And then she has always been reluctant to stop the steroids. So she either 2.5 milligram or 5 milligram has been her dose. So now she wants to do just one drug. She has to pick between 2. So the interesting thing is sometimes, like not sometimes, a lot of patients, they read a lot about their conditions and they want to drive a lot of conversations. So what would be preferred if I have to pick? I know it's all data-free zone.
What I would do personally in this particular case is dose her another dose of rituximab and then wean off both the steroids and calcineurin inhibitor.
Okay.
Yeah, I agree.
I like your opinion.
Yes.
Okay. So I know I have not been monitoring the chat, so I do want to, if there is anything in the chat or if there is nothing, I want to stop my slide share and have Dr. Aga, do you want me to share your case or I have it open? You're on mute.
I can do it. I've got
let me stop this.
presentation up. That way I can deal with my
And we can see your lovely screen MCD case. Okay, here we go.
Well, it was supposed to be cases, but I'm on call, so it turned into singular. So apologies for that. So yeah, I've got a very pleasant, and again, for the sake of this presentation, I've kind of fuzzed out the demographics for identification purposes. So this is a very pleasant 50-year-old female, history of migraines, as well as antiphospholipid antibody syndrome. She just had an antibody positive, and she had possibly a minor TIA some years ago. So she's been on aspirin since that time, was in her usual state of health till March of 2021. We went out on some prolonged hikings and she was noticing some aches and pains and was taking a bunch of Motrin, 400 milligrams a day, mostly, not more than that. And she reported pronounced edema on her lower extremity and a 20-pound weight gain. So she was really puffed up. She's a petite lady. And of note, she had her COVID vaccination a few weeks prior to that. So about 4 weeks prior to going on the trip, they'd taken their COVID vaccination. She was brought to the hospital after, the usual dillying and dallying with primary care doctors and diuretics and all that. And she was found to have severe AKI and nephrotic syndrome. She needed dialysis. A biopsy was performed that, per her report, revealed minimal change disease and ATN, which was later confirmed to be true. So she was started on renal replacement therapy, and she was started on prednisone 60 milligrams daily, just about in April 2021. How would you plan further management? So essentially, just for the sake of time, because we're getting close to the top of the hour, she was continued on 60 milligram a day for about 3 months or so. Her initial proteinuria at diagnosis was 16 gram per gram, and note that this was through a severe ATN requiring dialysis. After 3 months, she was in the 3 grams per gram range. After 4 months, she came to the 2 to 3 gram per gram range. A very slow prednisone taper was initiated. Over the next 3 to 4 months, she was brought down to about 10 milligrams. In the middle of December, she was with a proteinuria, early December, she had a proteinuria of 500 milligram per gram, and prednisone was down to 5 milligram per gram. So what would you guys call this? Complete remission, partial remission, happy with this, not happy with this? What are we looking at here? So if you're seeing her in clinic in December, what would you think? Are we happy with this? Not happy with this?
I mean, she is not meeting the criteria for complete remission.
Correct. So she's almost there, but not quite, right? And I think her prednisone's tapered a bit faster than we would want, right? So she should probably have been on a little bit more prednisone, but she hated the prednisone. It's entirely possible that she wasn't taking all of it anyways. So 2 weeks later, she called and says, well, all of my minimal change disease patients have dipsticks, urine dipsticks. So she said it's turning more positive and my urine has bubbles now. We checked the urine protein creatinine ratio at 7 grams per gram. And so this is very classic of this disease, right? It's an acute diffuse podocytopathy. We know she had 500 milligram per gram. And personally, I was not too displeased with that. I thought she had severe ATN. She probably has developed some secondary sclerotic lesions. If she's 500 or below, I'm actually okay with that. But now I knew better. She broke through to 7 grams per gram within 2 weeks. Okay, started becoming nephrotic again. Albumin went from the 4s to the 3s again. So what would you do now?
So we have a response from Dr. Kasser. I'm not sure, Dr. Kasser, if you're able to speak, but I can. So he would like to treat her with tacrolimus. But if you could share your words on that. I see you're on unmute.
Yes, thank you. I don't know, it's my just guess that we can start with tacrolimus.
Okay, so you're thinking that she's not going to respond to steroids again, and that we should probably go to alternate therapy. That's a thought. Any other ideas? Any other strategies? You're seeing this patient in clinic, obviously relapsing while on very low prednisone during a prednisone taper, which is not uncommon. More than half of the patients with minimal change are going to relapse at least once like this, sometimes higher numbers. And the numbers are higher if you're dealing with younger people. But she's 50, but still. So any other ideas? How would you like to treat this patient?
So we treated her. So the prednisone was the first course. Should we just go back to prednisone again and try like the full 6 months?
Yeah, so
She don't like steroids.
Oh yes. Yeah, that's true.
Doesn't like steroids, but we did do that. We put her back on steroids. She started on 60 milligrams a day. And 2 weeks later, her proteinuria was back down to 600 milligram per gram. So very, very quick response. What do you guys want to do now? So this is, the practical aspect of management. So like I said, a lot of people will break through with steroids. They will respond again, reconsultation with steroids. So the options here are to complete a full dose of steroids again, and most people would not respond. The other option that we can use in a situation like this, especially if steroid sparing is required, is to give her rituximab, or as Dr. Kasser said, we can add a calcineurin inhibitor and give her a calcineurin inhibitor and steroid combination. So what would you guys want to do in this case? So if you were seeing this patient in clinic, what would be your first recommendation to her, and what would be your alternative?
Rituximab is always an alternative for that.
Yeah, vitamin R is always on the cards.
Yeah.
So I think the textbook answer to this is we reconsolidate with steroids, But the real world answer is if we find that she's not going to take the steroids, then we can think in terms of rituximab. What do you think of the COVID vaccination? Do you think that's related in any way, or it's just a coincidence?
I mean, should I share one of my experience just recently, a patient with the COVID vaccine? And
Sure.
so I have a patient who had some year old, 82-year-old actually. He had 2 vaccines and then he had a booster. And after 3 weeks after the booster dose, he developed edema and typical presentation, like very. He actually has a 10-gram proteinuria, more than 10 grams actually. And we did a biopsy and he had a minimum change. And so with some ATN forming, so he was put on dialysis and we started on steroids, and he now off dialysis and his creatinine has improved over 2 months, pretty much back to normal baseline, which is 1.3, 1.4. So it clearly happened after the booster dose.
Yeah, so there's a whole subgenre of literature coming up, which is tying up COVID vaccination to various forms of glomerular disease. Minimal change disease has been described, FSGS has been described, lupus precipitation and lupus nephritis precipitation have been described, ANCA-associated vasculitis has been described. So I think it's just immune upregulation because of the stimulation, and it leads to various immunologic phenomena. So there may be some causality here. It's kind of hard to pin it, but the temporal association that she got the vaccination and perfectly normal, and 4 weeks later she was nephrotic, may suggest that there's something to do with the vaccine. And if you look at all the major journals on their early publishing sections, more than half of the articles are case reports of various glomerular disease in response to COVID vaccination. So there may be something there. There's at least a very strong signal. I don't think it changes the management in any way. So I think this is kind of an interesting piece along with that this was related to COVID vaccination. But she has behaved fairly in confirmation with how an adult minimal change disease patient would behave. She responded almost completely, and then she relapsed as we were tapering steroids. She has responded very, very quickly back to initiation of steroids, just as a minimal change disease patient would in a relapse state. So she's steroid sensitive. And if she's able to swallow, no pun intended, another course of steroids, we'll do that. Otherwise, we'll probably give her a dose of rituximab.
Okay, so why not CNI?
Why would I want her to be subjected to a long course of a nephrotoxic medicine with requirements of frequent blood draws, whereas 1 dose of rituximab and you're done?
Yep. So plus, I think he already had an episode of acute renal failure, which was dialysis dependent. So now I think the COVID itself has a pattern of injury in kidneys and in the GN world, and COVID vaccine as well. I don't know which way the world is going to go.
Yeah, so the glomerular pattern that you see with COVID infection itself, in the biggest chunk that you see in those is a collapsing pattern of glomerulopathy, which is now known as COVAN, COVID-associated nephropathy, just as HIVAN was. HIVAN is exactly the same thing. It's a collapsing GN. And essentially, this is almost exclusively seen in patients who are homozygous for the APOL1 gene mutation. So those people are always at risk for podocyte dysfunction in high interferon states. So when you have a very high interferon state, that leads to increased transcription of the APOL gene product. The APOL gene product out of mutated genes is toxic to the podocytes. So it leads to an acute diffuse podocytopathy, which presents as a collapsing GN. So that's the biggest chunk. So when you see somebody with COVID-associated kidney disease, they either got ATN because they're sick, or they've got COVAN. Now, you will see case reports because COVID leads to immune activation as well, and sometimes a hyperimmune response. So you will see a potpourri of other causes of immunologic glomerular disease, but they are more frequently seen after vaccination. With COVID, biggest bunch is COVAN in glomerular disease, and then smaller smatterings of minimal change or FSGS or other stuff.
Thank you. I think we have interesting discussion today. I really want to thank all of you. This has increased my knowledge too. I'm very happy today because of that. So any other comments, any other questions?
Well, I have just a question. I mean, like, I want to ask other people's experience. This tacrolimus, not tacrolimus, rituximab actually is a relatively new treatment options. So I personally don't have any experience on that. I'm just want to know other people's experience. Have they used rituximab for a patient with the minimum change and how the response has been? Because my approach was that the patient is elderly. Most of the patients I have seen are like 60 or older, that much. And I try not to use them tacrolimus or cyclosporin because of the worry about their nephrotoxicity. And as a steroid sparing agent, I'm using CellCept most of the time, and it has worked pretty good. But what has been the experience with the rituximab so far? Anyone can share his or her experience? Or it's still very new option?
It's been around for a long
Yes.
time. I use it quite frequently, and it works quite well.
May I? For children, we've used rituximab as one of the last resorts so far in our practice. So we may have given Ritux, I think, about 10 or 12 children. And those with steroid-resistant nephrotic syndrome would not do so well. The steroid-dependent ones are the ones that would respond very well. And the response to therapy with Ritux is almost comparable to cyclophosphamide given orally over 3 months. But the cost of cyclophosphamide versus 2 doses of Ritux is exponentially different. So in our setup, we would prefer for steroid-dependent ones to give them a trial of cyclophosphamide first, and almost 75% to 78% would go into a sustained remission, just like Ritux. For the steroid-resistant variety, those whom we have no choice left, we have given them with monitoring of CD19 levels, bringing them down less than 1%, or those with them hit them again, second dose within 2 weeks. Still, we're yet to see a good response of Ritux in that special group. Another thing is we're not sure that since Ritux takes a little longer to act, it may take up to 6 months. And those edematous children, we don't know how to maintain them till we see that response of Ritux. So should we go back on their baseline therapy with CNIs or give them MMF? Any thoughts, Dr. Agha? A child who has received Ritux, how would you maintain them till you see the response?
If they're frankly nephrotic, then I would keep them on baseline immunosuppression till the time their nephrosis is controlled. Otherwise, they will be at risk for all the complications of being nephrotic. So this particular patient that I presented is a good example where she became nephrotic. So I haven't given her rituximab yet. I put her back on the steroids. She's gone back into remission. The good thing about minimal changes, you get into remission fairly fast, month, 2 months. Most people are in remission, even on the adult side, if your diagnosis is correct. And then you can, in that period of time, so in the United States, you have to get approvals, which takes several weeks to do. It's not a very fast process. So yeah, I have to fight with somebody to get a peer-to-peer done to make sure that they approve the rituximab because of the cost. And then we dose the rituximab and wean off the immunosuppression.
So if in that case, the rituximab induction dose, like 2 doses or just 1 dose?
Usually I give 2 doses initially, and then
Okay.
doing maintenance, I would do 500 milligrams or a gram if I'm doing.
I think 2 things. One is, I think there was a comment about the question about the maintenance dose of rituximab, which I have, and I do want to share a patient. So let me go with that. And then, so the dosage, so we have 2 protocols. One is the hematology dose, which is weekly, 4 dosage, or rheumatology dose, which is 2 doses every like 15 days apart. And the rheumatology one is like each time you give higher dose. For ease and convenience, I usually gravitate towards that. So maintenance, I think that is every 6 months, and there are data in vasculitis world predominantly, and I think membranous as well. So the dose is just 1 dose, right? When you go with the every 6 months, you just give 1 dose, not like 2 doses. So Avas, I had a patient when I was a fellow. This was like, more than 10 years ago. Tall guy. He was like close to 7 feet tall. So he was a veteran and very big guy. I remember I did the biopsy with my then chief. So he had acute renal failure. He was a veteran. My chief saw him at the veteran hospital in VA hospital. So then he was moved to our hospital for dialysis and everything else. Everything was clear-cut acute renal failure, no explanation. The biopsy was done 3 months into dialysis. So he was on dialysis for 3 months. Then we decided to do biopsy. We were kind of hesitant to do biopsy because of his body size and body habitus. I did the biopsy, I remember, with my chief. So it was very difficult biopsy. You know how long the needle is? It went almost all the way in to reach to the kidney. We did some measurement that needle was long enough to do the biopsy. And guess what? We found minimal change disease, and there was not ATN, there was nothing else going on. He was on dialysis and he used to gain like 8 kilos in between dialysis sessions. So it was like a management challenging and nightmare. So we discussed the options, and he said he was allergic to steroids. Can you imagine like somebody who's allergic to steroids? And there was some autoimmune condition where he had used CNI, which I think we did not want to use because of his renal failure. So it was either we give him cyclophosphamide or we give him rituximab. So he was given cyclophosphamide. For 3 months, there was no response. He was on dialysis. Then we gave him 1 dose of rituximab. It took him a month, and all of a sudden he was not gaining. We were able to remove the fluid. And then his creatinine started to improve. He actually came off of dialysis. This was rare enough or robust enough that we should have written a case report about it, but he responded very well. His nephrotic syndrome improved, as well as his acute renal failure was, he came off of dialysis, and I saw him, a few years in the outpatient clinic afterwards before he went to another VA hospital. So that was like, experienced long time ago. So we have a low threshold to use rituximab in these cases, in these situations, and it has worked almost all the times.
Maybe I'm biased because I have good initial success with the CellCept. I have used a lot of CellCept also.
In minimal change?
In minimal change, yes. As a potassium sparing, steroid sparing agent. Particularly an older patient who I'm worried about nephrotoxicity from cyclosporin or tacrolimus.
Irfan, you want to say something? You just unmuted yourself.
No, I was just, I've used it, but not as frequently. And I tend to go to rituximab much earlier than I go to much sooner than I would go to CellCept.
Yeah, I have the same approach.
No, I learned you don't use steroids with MMF?
Rituximab more now, because this is a very good learning experience. Good for me.
I'm sorry, Dr. West, do you use steroids along with MMF or just MMF?
Oh, just, in the beginning, like obviously the patient comes to remission. After that, just CellCept, MMF, no steroid.
Interesting.
So really try to maintain them, like vasculitis example or something.
Yeah. I mean, I have a patient right now. I mean, she's on CellCept for some time. I mean, when I very, very minimum dose, like just believe me or not, 250 milligram daily, she's okay. When you take off, you get relapse. It was very strange. I mean, you put like back on even just 1 gram of CellCept, she goes into, remission again.
So that patient needs some immunosuppression.
Yeah, but so small dose, but not completely off.
All righty. It's almost going to be 1:30 soon. Any other questions, any comments, any closing remarks?
So I have one question. How much time it will take for the minimal change to end up in a renal failure without any treatment? I mean, what is the course of the disease without any treatment?
Or natural history of the disease without treatment.
Yes.
So say if this patient had it 100 years ago, what was happening?
No. If we have getting patients who are in renal failure with glomerulonephritis, we don't know what was the cause of that. So in our villages and in our remote areas, patients come with increased creatinine, and we put them on dialysis, but we don't know the course of glomerulonephritis, what has happened to them. So can you guess or some idea about that, what minimal change will take time if that patient got in 12 years of age or 15 years of age, and after 10 years he got into renal failure because they did not get any treatment at that time?
So the question is that if somebody has had like a minimal change disease as a diagnosis as a child, now they have a relapse which also led to acute renal failure, and now they are too late into the case, and we don't know what's going to be the prognosis of ARF. I'm just trying to understand the question. I don't know, Ali, if you understood it maybe better
Yes,
than I could.
yes. I think what Dr. Kesser is pointing out towards is the biggest etiology of patients who are starting on dialysis in Pakistan is an unknown etiology. They come to us with a small shrunken kidney, and they may have a history 5-10 years ago. They may have had a little bit swelling, and then it resolved and they were completely well till they presented with advanced uremia. Am I getting it right, Dr. Kesser?
Yes, you are right, but that's right. That was
Yes.
I'm asking. Yeah.
So about 60% of patients at SIUT present with ESKD secondary to unknown etiology. And at that time, they have small shrunken kidneys and we cannot biopsy. Those with borderline size kidneys, and we have attempted biopsy and they will show just sclerosing GN. So we have no way to find out what actually happened. So what Dr. Kesser is alluding to is it possible that they had MCD 10, 15 years ago and now without any edema and obviously proteinuria was not checked, but still if they would have, for MCD to develop renal failure, the primary mechanism is continuous persistent high grade proteinuria. Otherwise, to stay silent and cause ESKD over 10 years, in my opinion, I don't think it's very likely. It's some other kind of GN, maybe some complement
Rapidly
mediated.
progressive, yes.
Yes, some crescentic or something of other complement mediated that has sclerosed their gloms, and they compensate well with remaining gloms for a while till they all collapse like a whole thing. And when you biopsy them, they're just globally sclerosed.
Yeah, that's right.
So maybe by that time it's all kind of burnout kidney, and even whatever the biopsy do, it will show you the end stage histopathological changes, whatever the common pathway is. So maybe Ali, if you can help me understand. So what's the natural history of minimal change disease if untreated?
Oh, I doubt if anyone has left an MCD untreated. It's so difficult because the main hallmark of a glomerular nephrotic syndrome is that it has a progressively increasing edema. and that edema would become disabling. So those late responders would come to us, can barely walk, and they have such severe anasarca that sometimes we may have to do we have to take many aggressive measures just to treat edema, like putting in tubes and draining that ascitic fluid out so the diaphragm can pull down a little bit and they can breathe. So that, I think, is the natural course, that if left untreated, the edema will progressively increase till it would become disabling and would compromise their breathing, and then, further deterioration. Renal failure in an MCD would come much later in the course. It's not usually rapid. If it happens so, then it is an atypical variety and which is rare. The commonest one is that the edema would increase so much that they would have to seek treatment.
Do you see the complication from long-standing untreated edema and low albumin, like a DVT or any like this thrombotic event?
Yes. Fortunately, not so commonly. There are quite a few children who do not respond to usual therapy and they stay edematous and with very low albumins for a very long time, with very heavy proteinuria, so probably excreting a lot of antithrombin 3s. But given the number of children that are that proteinuric, the number of children that we see with thrombosis are much less. All I can recall in last 15 years, I may have seen less than 10 children with thrombosis.
So do you consider putting an anticoagulant to those children who are not responding or they remain with low albumin?
Okay, so 2-3 of the children had sinus vein thrombosis in their heads and would come back with, would have severe headache, disabling headache. And the only thing we could do was to give them immune suppression, anticoagulation. Anticoagulation in children is tricky because, it is, as soon as the child would start feeling a little bit better, it is impossible to keep them, injury free. They'll bang their head somewhere, or they'll jump from somewhere, or some other kid would push them and they'll get injured. And the risk of developing serious bleeding with anticoagulation, with the level of anticoagulation that you need, more up to 2 to 3 INR, and then to maintain that INR with warfarin is almost impossible. Rivaroxaban, although we are giving it now, but is expensive and they are not very compliant. It's not easy to take. Clexane and all those injectable anticoagulants, they have to inject themselves, and again, that is a problem on a long-term basis. And for all the recommendations you see for thrombosis, they require anticoagulation at least for 6 months. And that is a problem. So we see it rarely, and then provide them anticoagulation for a long term is even more rare. Recently, we lost a child to intracranial bleed who was receiving anticoagulation for similar arterial thrombus that had led to gangrene in his toes. So we were anticoagulating, and he was, while in the hospital without any apparent injury, developed a severe intracranial bleed, and we lost him. So we're very scared of giving anticoagulation to children. Fortunately, it's rare thrombosis. We don't require that often.
Because they're active. That's why maybe.
Yes.
Wes, you were saying something.
No, that's it. I said it's rare probably because they are more active as compared to older people.
Mm-hmm.
Or maybe their endothelium is much fresh than the older people.
Absolutely.
Well, I think it's also a question of how quickly you respond, right? So you respond very fast. They're not very highly nephrotic for a long period of time. So in minimal change disease, sometimes when I'm starting treatment, even if they're frankly nephrotic and the albumin is low, and I see a very quick response in weeks, I may not anticoagulate them. So the thrombophilic profile of minimal change disease or even immune factor related FSGS is different from membranous. So the peak incidence of thrombosis in membranous is at the time of diagnosis, because membranous has been active for months before it presents. So it's a slow burn disease. So it's a diffuse podocytopathy, but it's not an acute diffuse podocytopathy. Minimal change disease is an acute diffuse podocytopathy. It hasn't had enough time. So the peak incidence of thrombophilic events in minimal change disease or even an immune factor related FSGS is 6 to 9 months after diagnosis. So you have a little bit of play in time. So if their albumin is 1.4, I would say, Jesus, let's put them on, immunosuppression, but they're 2.5 and I have a feel that they're going to respond very quickly. I might wait 2 or 3 weeks and then put them on anticoagulation if they're lingering. Like this lady, she has APLA, she's just on aspirin, but when she relapsed, I didn't put her back on anticoagulation and just put her back on steroids. Within 2 or 3 weeks, she has responded. Proteinuria subnephrotic now. So her risk is minimal. So her risk of anticoagulation is probably more than her risk of protection from the anticoagulation. So you have to kind of develop that. The other thing is my threshold of putting somebody on anticoagulation is much lower for membranous. If I see somebody with membranous albumin is 3 and 2.5 and dropping, I might put them on anticoagulation. Then for minimal change disease, I really wait for them to drop below 2 before I do that.
And just you anticoagulate them with aspirin or warfarin?
Aspirin is antiplatelet, of course. So for anticoagulation, we either use direct NA inhibitors or we use warfarin.
Warfarin.
But generally,
INR of 2, 2.5?
2.5 to 3. So,
I mean, we hardly use warfarin because it's so difficult to control. I mean,
yeah.
but
I was going to say that I haven't used warfarin in a while in these patients. I use Eliquis or something.
Yeah.
And just to take a stab at Dr. Kasser's question, so if you don't treat minimal change disease, if somebody's got minimal change at 815 or 880, you will have persistent nephrotic syndrome. There's a very small percentage of cases that can actually have spontaneous remission. So the miracle cures that everything got better. Their regulatory T cells were able to control the disease process, and that's how that happens. But if you let it burn, then over a long period of time, they will develop glomerular sclerosis because of persistent proteinuria and sclerosis of the podocytes. They will develop progressive glomerular sclerosis, and eventually they'll develop focal and then global sclerotic lesions. And that's when they start developing renal insufficiency. So that's when they come to us, and as adults, they've got protein in the urine. Oh, I've got protein all my life. My doctor's been telling me that I had protein in my urine. And then if they were biopsied, you'd find an end-stage kidney with a lot of glomerular sclerosis. If they were never biopsied, we just put them on the list or start dialysis that, yeah, they had some form of nephrotic syndrome and now, they're end stage. And especially if you get this disease as a child, your biggest risk as a child is not complications of the nephrotic syndrome itself. I mean, they're substantial, but you also are at risk for infection. So what gets you is bacterial infection or something.
Yes, very right. Very right, sir. Thank you.
Well, thank you, everyone. Thank you for joining. Thank you for listening. Thank you for participating. I think this really brings us towards the end of the session. Thank you and have a great rest of the day and next week.
Thank you, everybody. Have a good day.
Thank you, everybody.
Thank you.
Good night from us.
Good night.